Welcome to the Gastrointestinal Endoscopy Author Interview Series. I am Dr. Glenn Eisen, the Editor-in-Chief of Gastrointestinal Endoscopy. With me today is Dr. Suryakanth Gurudu from Mayo Clinic, Scottsdale. He is an Assistant Professor of Medicine and also the Director of Endoscopy. We will be discussing his paper, which is in press in GIE, entitled Increased Adenoma Detection Rate with System-Wide Implementation of a Split-Dose Preparation for Colonoscopy. Welcome, Dr. Gurudu.
Thank you, Dr. Eisen.
So my first question for you is, what prompted you to perform this study?
There were several randomized studies showing improved quality of the preparation and patient tolerance with split dose preparation. But we don't know its effects on more important quality measures such as adenoma detection rate and colonoscopy completion rate. And that is the reason why we started this study.
Okay. And I see that this is a retrospective study design, so you merely look back at the data you've been collecting overall?
Right.
When did your group decide to change from single-dose prep to split-dose prep? Because I noticed one of the cohorts is from 2009 and one is subsequently from 2011.
We started the process around January 2010. And we went with several referring physicians. We talked with several referring physicians regarding the importance of split dose preparation, and we implemented it at around September 2010. And then we prospectively collected the data of the outcomes of split dose preparation from October 2010 to March 2011. So we compared the data of 2009, that is pre-implementation time, to October 2010 to March 2011 after implementation of split dose preparation.
Was there any pushback from the patients in your clinic as far as doing the split dose preparation? Because oftentimes the second dose is very early in the morning, the day of the colonoscopy.
There was some, but what we did was in the patient instructions, we gave enough language. If patients are coming for very early morning procedures, or they have a long travel time, we gave a choice of taking all of the preparation night before. So there were, in fact, 26% of our patients after implementation did night before preparation.
Okay. And did you find differences between the two groups?
We did not, interestingly. The reason I think is most of these non-split dose preparation patients in the after implementation group had their colonoscopies in the morning hours, very early morning hours. Okay. So that might be one reason why there was no difference in the quality outcomes, though there was overall quality of the preparation was slightly better in split dose preparation, but we did not see this significant difference in the adenoma detection rate or completion rates.
And that's for the 2011 group?
2011.
But you did see differences comparing 2009 versus 2011. Can you discuss that?
Sure. So after implementation of split dose preparation, the overall split dose use increased from 9% to 74% in our patient population. The quality of the preparation significantly improved in the split dose preparation group after implementation. Particularly, the good to excellent preparation quality improved from 35% to 54%. The colonoscopy completion rate improved from 93.5% to 95.5%. And adenoma detection rate, which is the most important outcome measure, improved overall from 27% to 32%.
Okay. Could there be other factors that might account for that improvement in your adenoma detection rate, given that these were non-contemporaneous comparisons?
That's an interesting question, and it's an important one. We looked at our data in the pre-implementation time. We divided that into 6-month periods, and there was no difference in the first 6-month quality measures to last 6-month quality measures in the pre-implementation time period. And the effects are significantly improved after implementation. Again, you cannot completely rule out other factors like physicians are becoming more aware of the quality measures, but we did look that retrospectively to see whether there was any gradual improvement in the adenoma detection rate, and we did not see that in the pre-implementation time period.
Okay. So we know that now that adenoma detection rate is a strong quality measure, perhaps one of the strongest. There are subsections of that that may be even more important, such as polyps greater than a centimeter in size that are adenomas, or perhaps sessile serrated adenomas, things such as that. Did you look at that as well?
Yeah, we did. The large polyp detection rate improved from 6.7% to 8.2%, which is a significant improvement. Whereas sessile serrated polyp detection rate did not improve significantly, 3.3% before to 3.4% after implementation of split dose preparation.
Okay. Now you mentioned that with the split dose prep there was a significant improvement in the good and excellent preps, but 54% or so still seems kind of low.
In our classification, we divided into good to excellent, fair, and poor inadequate preparations. So fair are also considered as reasonably good enough to follow the screening and surveillance guidelines. So only the important group where we need to work on is the poor or inadequate group, which decreased from 10.6% to 8.2%, which is a significant decrease in the quality of the.
Did you utilize a validated prep scale, or because this was retrospective you weren't able to do that?
In the past, we used modified Adenoma scale. We could not do a validated scale for this study, but since the study is done, we implemented Boston Bowel Preparation Scale, which is more validated in our practice going forward.
So that's one of the things that's changed in your practice because of what you found.
Right.
Any other things you're doing differently, or you're just continuing forward with split prep and utilizing a validated prep scale?
Basically, we are kind of enforcing and showing the results to our referring physicians about split dose preparation, and moving forward, we would like to get maximum compliance with split dose preparation.
Okay. Is there anything else you'd like to leave our readers with as far as your paper?
There is, for afternoon colonoscopies, if someone wants to take entire preparation the morning of the colonoscopy, that may be an option. What I wanted to give to the audience is give the choices and maximize the quality of the, improve the quality of the preparation by maximizing use of split dose preparation.
Okay. Thank you very much.
Thank you.
Nice to see you.